Hey, how are you?
Hey, good. How's it going?
Awesome.
How's your shift so far?
Good. Good. How's you doing?
Pretty good.
All right. Ooh, geez.
Sorry, this
Sorry about
rolls.
that. Okay, well, this is that.
Well, let's go ahead and get our handoff done so you can get home and be done for the day.
Perfect. Perfect. So I tried to set you up for some success today.
Okay, good.
So we'll be handing off Mrs. Joan Smith. She's a 63-year-old female.
Okay.
She came in for a total abdominal hysterectomy, bilateral south histopenogram,
Okay.
and then exploratory for ovarian cancer stage 3.
Stage 3. Okay.
Her vital signs have been pretty stable.
Okay.
Blood pressure is 120, 140s over 70s to 80s.
Okay.
Heart rate's been normal sinus rhythm 70s to 90s. Respiratory rate's been fine, 12 to 16. She's setting 96% of her urine.
Okay.
Her urine output's been awesome. So she's been over 50 milliliters.
Oh, okay, good. Good.
She is post-op day 1.
Okay.
So before we get ready to leave, I'm going to go ahead and discontinue that fully.
Oh, okay.
She is still on morphine PCA.
Mm-hmm.
She's a full coder.
Okay.
Lab work's been completely normal, HNH is stable.
Okay.
She's a little bit overweight, so she is considered a fall risk.
Okay.
I've not had any problems with her. You know, she's been using the call light and really cooperative and understanding.
Okay. Good. Good. You said her urine output's good. Is that right?
Yes.
But you are going to go ahead and remove the Foley. Is that right?
Yeah, we're going to go ahead and remove that fully because she's 24 hours post-op.
Okay. Do you think there's any way we can leave that in for the night? I mean, I know the rule is 24 hours. We are so understaffed right now, and I'm just worried if she's a fall risk. I mean, it's only 12 more hours. Just if we could leave that in for tonight, then tomorrow when you guys are, I mean, you're full staff during the day.
I totally understand where you're coming from. But, you know, I got the physician order to go ahead and discontinue it. What I can do is I'll go ahead and I'll make sure that I set everything up in the room for you. So I'll have that bladder scanner alongside of the bed for you so you don't have to go and look for it. I'll also, you know, let the tech know and I'll let the secretary know as well.
Okay.
To be just kind of paying attention and watching out for her.
Yeah.
I'll reiterate the use of the call light for her. And if you really need, I can stick around just for a little bit while I'm finishing up my charting to see if we can get her to pee before I leave.
Okay, I'm just really concerned. I mean, like I said, we're short-staffed tonight, and we've had some issue with the fall risks. I mean, you know, that's part of our incentive program, and I really don't want to lose that money for our floor.
Yeah.
It's only 12 hours, and I mean, she's probably going to be sleeping, so it's not like she's really going to notice that she still has that catheter. I mean, if we could just, it would be so much easier on us and so much easier on me if we could just leave it in for the night. I just really, if you could do that, that would be so much easier for all of us here on nights. I mean, it's only 12 hours. It's not like, I mean, I can't believe she'd get an infection from just that, especially if her output's good.
Like I said, I totally understand what you're saying. Unfortunately, it isn't about us. It's all about our patients. So we'll go ahead, like I said, I will set you up for success. I'll have that bladder scanner alongside of the bed for you. I'll even go ahead and write it on the whiteboard so if her urine output isn't where it needs to be, that you're already set up for that. And like I said, she goes ahead and she follows the rules and she knows to use her call light and whatnot. I think that realistically, she's not going to be an issue for you.
Okay, I mean, I guess with the stuff that you got set up and doing some of the prep ahead of time,
I want you to have a good night too. I really do.
I know, I guess it'll be okay.
Good work.
What's behind the door?
Oh, sorry.
I was like, she's still going. Wait,
Sorry about that. I didn't see that.
You're good. Step out, let you guys do your thing.
The judgment immense.
You gotta be diverse, right?
Yeah.
You gotta know all the roles.
You okay?
Trying to hide.
Okay.
So I guess we could start with their initial handoff. So how is our catheters discussed in nursing handoff, or do you have any electronic tools that prompt you or prompt how many days the catheter's been in? What are your processes for handoff?
When our nursing staff's handing out, they're supposed to discuss the Foley. Does it still need to be in? When was it placed? If it's post-op, can you take it out before the 24 hours? Is that appropriate? So we've educated, doesn't mean they do. They've been educated to always question it, why is it in? So.
Charge nurses as well.
The charge nurse is also around on the catheters and round with the nurses to make sure that they're at least addressing them.
I was just gonna say, it's not only nurse to nurse handoff either, it's also charge nurse to charge nurse. So we kinda have like a second line of defense. They have reports on their dashboard that they run and go from there, so. It's the nurse and the charge nurses kinda work together.
In a perfect world. You always have to say that. It's designed to work that way.
And then, okay, so once the Foley's removed, do you guys have bladder scanning protocols? I know she mentioned that she keeps the scanner near. Do you guys have protocols for it?
Yep, we've got an algorithm we use for post-Foley removal so that the nursing staff can actually perform one straight cath once that Foley's been removed without a physician's order.
It comes with the removal of the Foley. You get one bladder scan and one straight cath. And then if they don't pee again for 6 hours, then you need an order to
Do anything else?
continue, every 6 hours, every 8 hours. Whatever the physician then deems appropriate. So you get one freebie.
Is this the type of conversation that you know happens in shift change often, or is this something not so much?
It's supposed to.
I did
It
notice.
I doubt that would ever happen because we do bedside reports, so I highly doubt they would say that in front of the patient.
Okay.
Which easier for me.
I did notice
So
that
maybe
would have been a
that
good time
could
to
change
use.
things a lot. Like how much does the patient know about what's happening or supposed to happen? Sorry, go ahead.
Oh, it's okay. I was just gonna say that would have been a good time to use your AI, I guess, noticing it from an outside perspective. It's not the first thing to say, but I hear what you're saying, but I'm concerned because the longer the Foley is in, the higher the infection rate is. And our policy is to take it out after 24 hours. What are your thoughts on our policy? Or what are your thoughts on me taking out the Foley before I leave? That kind of, in a perfect world.
Well, and I think some of the discussion that happened also kind of leads back to if there are conflicting goals, right? Okay, yeah, I know, we're looking at Connie's real close, but we're also looking at falls. And if we got to keep trying to get her up, and if I can't get there in time, she tries to get up on her own, or then we lead to fall. And so it's which motivation is stronger, right? The Caudy versus the fall, or the other thing, which one? And this could be a good conversation to figure that out.
What other strategies do you guys use in your own institutions? I heard about the bladder scanner and all the protocol stuff, but are there other things that you guys do for your patients that really work in terms of managing a patient that would probably 5 years ago have had a catheter in?
We do brief wane.
I'm sorry.
Brief wane, so like your wane pads and things like that.
Right.
Everybody's got bed alarms on. We do Q1 hour checks on patients between the techs and the nurse.
We have fall scores every shift. If there's certain fall scores, fall in a certain category. We also did for a while, we piloted, which I wish we could go back to, physician only placing in this was a few years ago, that nurses within their work chart within Epic, they weren't allowed, they couldn't find the actual Foley order. So the nurses couldn't, on their dashboard, put in the Foley order, only the physicians could put it in. And so when you opened up the order, you have to put why the patients getting the Foley, what kind of Foley you're putting in, even if it's just a straight cath order, that's something,
That was
you know, that
part
we
of something
piloted
that the,
part of a while
well,
ago.
the order set, it makes the physician choose the least, the least, I guess, the least restrictive method, or however, the
Right.
one that would cause the least amount of, harm to the
Potential
patient,
harm,
yeah.
yeah.
So they can choose from, okay, brief wing, they can choose from Texas catheter, they can
yeah.
choose from
Straight cath.
straight cath, and then there's a Foley catheter insertion, but each one needs to have the indication. And then there's an auto removal for nursing staff, so that they can automatically pull it out if the patient doesn't meet that indication. The physician doesn't want nurse to remove the catheter, they have to uncheck a box.
Yeah, and they have to document every day why that Foley, physicians and nurses, why that Foley's still in if it doesn't meet criteria. So say it's a renal patient, this happens frequently, and renal decides they want it for accurate eyes and O's, even though the patient's not critically ill, they just have acute renal failure or whatever. So they have to document every day specifically why they have that, even though it doesn't meet our protocol.
Do you guys still use bedside commodes just to make life easier for the techs? and
But yeah,
the-
especially in ICUs.
If somebody's like has mobility issues, for sure.
Yeah.
I know our ortho floor, when they redid it, they actually bought a commode for every room
Yeah,
for those physically impaired knees and hips and things.
right.
So when physical therapy was in there, they didn't have to wait on a commode, they could teach them kind of how to get to the commode properly and how to get it.
So one of the things that I'm looking at for critical care, the nurses, since we're talking about potentially discontinuing Foley's after 7 days, is that the new technology that's out there. So there's actually an incontinence pad.
Right.
So we're looking at that as an option, but it's balancing that alarm fatigue.
Yeah.
But
Is there,
giving,
so there's a pad that the alarm goes off if it's wet? You're kidding me, I didn't even know that. Wow.
so but one of the biggest, challenges in asking the nursing staff, why are you so afraid your patient not having a catheter? What does that, what are you giving up?
Right.
And it's that, not knowing that they're wet. Because, and then speaking to them, they could do their hourly rounding. So you could literally round at 0805,
Yeah.
but not get back to your patient until 0950, and that is reality.
Oh, sure it is.
Especially if you have, the acuity of your
Sure,
assignment. Your
807.
patient could have urinated
Uh-huh.
at 0807, and now
Right.
I have that guilt, that caregiver guilt.
Yeah.
That I don't know when you wet,
Uh-huh.
and now you could have potentially been sitting in that for almost 2 hours. So then the give is understanding that what they're feeling is real,
Yeah.
and it is a real concern, and no, we don't want our patients sitting there. So then looking at different technologies such as that incontinence pad.
Yeah.
Is that what it's used for? No, but am I willing to look at that as an opportunity to make, yes?
Yeah, absolutely.
So
And-
that's just something we're looking at.
Yeah, and I really appreciate the fact that you're diving down into some of the issues that your nurses have to wrestle with. I think healthcare providers and nurses in particular are really good at beating ourselves up, right? So, yeah, I think that's really a valuable practice to try to take that dive down.
I think both of you had mentioned in a perfect world. Well, we obviously feel in a perfect world where you're there at 8:05, 9:05. There is that gap. So what can we do in the real world, not the perfect world, to bring this down? So, nice job facilitating. What we're going to do now is we're going to go ahead and go for round 2. So you're up for the facilitation, and we try to make it as easy as possible. We have a sample scripted. If you just want to read word for word off of that, that's perfectly fine. Jamie, you're going to be our participant. So we'll just stay here and do this part. We don't need to go back and forth. And then when you're done, we'll go in the hallway. You'll go out that way. Come in and do it all over. So just like you've never seen it before.
Just like I've never seen. Okay, we're on the med surge, and you're the day nurse. Have been taking care of a patient that's post-status, post-open exploratory laparotomy. or laparotomy and total abdominal hysterectomy. For stage 2 ovarian cancer, the patient is post-op day 1, has been on the floor for over 24 hours, still has the catheter in place, and you want to remove it before you leave. The nurse that is relieving you is going to give you a different point of view, and your goal is to advocate for the catheter removal.
Do you have any questions? You know what kind of stuff? Okay. So again, the majority of us will go out the back here and Jamie, you want to head up front and give us just a couple seconds and feel free to come on in.
How are you? Oh my gosh, I'm
good.
so ready to go home. This is, you do not know.
Ready to be at
Like
work.
you can't run fast enough.
Well, let's get this done so that you can get out of here.
All
What do
right,
you
let
got?
me talk about who we have today. Mrs. Jones, absolutely love her.
Okay.
So sweet, so
Great.
sweet. She's in room 100, in bed 1. She came to us yesterday from after surgery, having a total abdominal hysterectomy with a BSO, and they also did exploratory lab for ovarian cancer. Her vitals have been stable. She is on room air. Urine output's been very good, over 50 mils per hour.
Okay.
She is still NPO. She hasn't had a bowel movement yet. She has been moving around a little bit in the bed, and we did sit her on the side, but she's ready to start ambulating just
Okay.
a little bit. On PCA, full code. No problems with her lab, no allergies. Still has that catheter, a little overweight, and she is a fall risk.
Okay.
She has a history of sleep apnea, obese. She is on Zofran for nausea. Let's see. I will remove her catheter before we go. I haven't got around to that just yet. Had to be removed 24 hours post-op, and she just made that about 30 minutes ago. Surgeon's Dr. Blade. So what we need to work with her on is just mobility, getting her up to the side of the bed, making sure that we can hear those bowels. She hasn't had any BM yet, but she's passing gas, and then making sure we can move her diet
Okay.
forward.
So diet, movement. Okay. And I'm sorry, did you say you were going to go ahead and remove?
The catheter, yep, I'm gonna go in there and take her catheter out. She knows to expect me because I ran in there before I came here to get a report to tell her I was coming. I set all of my equipment in there, put a bladder scanner next to, in there as well, so
Okay.
that we can monitor her output.
I'm just really concerned. I know we've been really short-staffed at nights, and I mean our turnover can be really horrible with staff and stuff like that. I'm just really concerned about being able to get to her if she needs to get up. So I'm just thinking maybe if we could leave that catheter in for the night, and then have the morning crew take it out. I mean that would probably be a huge help to us, staffing wise, and just probably be easier so that she doesn't feel like she has to get up. So, I mean, if we can just leave that in and I can go ahead and pass on to the morning nurse, then we'll take that out in the morning.
I'm still gonna take it out because if I don't take it out, that's not following the physician's orders, and he wants it to come out, and then she's gonna be more risk for infection if we leave it in. If we keep it in, she's not gonna get the movement that she needs to help and increase her mobility the way that they want her to, following her orders.
Yeah, but I mean, with the fall risk, that's a huge concern. We've had that as one of our incentive programs again this year, and we keep getting dinged on it with people. And I mean, if you said she's obese or slightly obese, she's just starting to do movement. I mean, if she decides to get up on her own in the middle of the night to go to the bathroom, that could be huge.
And she's alert and oriented. I've talked to her about making sure she puts on the call light before she gets up or waits for assistance to get up. She knows to call us, like I said, and I've turned on her bed alarm so that we know if she's even trying to move. It's set on the extra sensitive setting so that we can actually hear that.
I don't know, I mean, it is so crazy at night, and there's like, there's half of what we need staff-wise. It's just,
And-
I don't really think it's gonna be a big deal just to leave it in until the morning. I mean, Doc's not even gonna see her till the morning, so
I
he's not even
understand your
gonna.
concerns, and I've worked night shift too, and I know it's a little bit more difficult, but we have to do this for the safety of our patient, because not only are falls a risk for her, but infections are a risk as well. It's the right thing to do for her. So, thank you.
I give up, she wins.
Thank you. I just sometimes want to be like, suck it up, pick up the bowling, man up, it's not about you. And you have to be nice to people.
It's always about them.
Right, it's not about you, it's about the patient right now, so.
But if she's cutting corners on this, what else do you think?
Right, right.
But my thing is, I've seen this happen.
Mm-hmm.
The day shift nurse says, well, you know what, I'm not on tomorrow, I don't care, let's leave it in.
Yeah.
How many of you have had that happen?
Or you leave it for them and then you come back and it's still
Still
there the
there.
next day.
Right, so yeah, that's the one we've seen. You
They said
you
they
say,
were
yeah,
gonna
you
take
can
it
take it,
out.
they offer to take it out, yeah, go ahead, thank you for letting me leave. And then
It's still there.
we come in the next morning, that catheter's still in place because it was easier for them.
Or they took it out 10 minutes before their shift.
Ended? Yes, I just took that Foley out, so you have to feel like passing it on to you.
Or they just don't even tell you. Fully came out.
Yeah, you're looking for it on the
You see
bed.
in the charting, it came out 10 minutes ago.
So, I liked how you started off with, I've seen this happen and started the conversation that way. Some other things, I know we already talked about this quite a bit the first round, but, how could, ideally what would this look like? Like, how would this look every time in order to get the Foley out? Or
What if you, a lot of places do the bedside report. What if while you're in there doing bedside report, you're like, okay, we're gonna take out your catheter now, and just kind of did it so that nurse didn't have that opportunity to say, don't take it out, just do it during that bedside report, and then do everything right there.
It's putting that off-going shift kind of at risk as well, because it's understanding this kind of, she's throwing all the tools at her. We're short-staffed, I don't wanna get in trouble, come on, doctor's not even gonna see her, and it's difficult because we're all seasoned nurses. I've had that conversation, and you're not gonna deter me, but is that how one of my new grads, who's literally her first week off of orientation, gonna react? She's gonna be like, okay. So it's maybe understanding that, so I like that idea of during bedside shift report, let's just go ahead and do this, and it kind of removes even having to have that conversation and putting her in that.
Well, then the nurse that's coming on knows exactly when that catheter was removed. We had with our nurse-driven protocol, if it was deemed to remove a catheter, it was set to be removed at 6 o'clock in the morning. And we found that, especially in ICU, none of the nurses were removing it at 6 o'clock because they didn't have labs back, they didn't have all the information. Well, now it's going on to the next shift, and the next shift is like, well, it's just gonna stay in. So then we tried having a discussion, well, maybe we should put it like 8 o'clock or a time like that. And our urologist was like, well, don't make it too late, because I don't want phone calls.
I don't want to come in,
late
yeah.
night. So we're still trying to hone in when a good time.
It's also being able to, if something's not taken care of, being able to, like if you've got some kind of a system or like a event reporting system, if you can put something like that in an event reporting system, that helps hold people accountable, for they're supposed to take out this Foley at 6, it's 8 o'clock, I'm just not gonna report the Foley's still in place. Or it's because then people, okay, if they're held accountable for not doing something or doing an order, then most likely they're not gonna repeat that mistake again, so.
And it's getting people to make sure that they're using that event reporting system. A lot of times, we have that in place, but nurses are like, well, I don't have time to enter that.
Right.
And I think there's also a concern, we are such strong advocates for using these event reporting systems, and we want to instill trust in the staff in using them. And it's that fine line between using them for accountability, versus using them
To
or
tell
making them a
them,
trusted
yeah.
tool.
Yeah.
So, you know, it's a hard line
But
to
I
walk,
think if you're actually using them though, you can identify where those
where the gaps are.
Yeah.
I don't
Use them
disagree at
appropriately.
all.
I also think that when it comes down to this, you know, ownership, and granted, we all have to be partners in that,
Sure.
but it's that one person who's going to hold the ultimate accountability, and that responsibility can't be shuffled around.
Mhm.
Because that's where we kind of struggled, you know, who's going to own it? And if you have too many owners, then nobody owns it.
Yeah, diffusion of responsibility. Sure.
So, yeah, in your book, we have, you know, all the sample scripting stuff. You guys, again, you try to make it as clear as possible and, you know, pretty easy language. You have the sim setup. You have sample scripting for kind of like the big overview of why we're here. You can take with you. You try to set up sims that, again, you do anywhere. You know, a conference room, the break room, 5 minutes, you know, where nobody's at for something like this. You all get a task trainer so you can do that. So you don't have to be proficient in sim. I know a lot of you hadn't had sim experience. Hopefully we've shown you the value of this and finding out maybe where some of those gaps are in your facility. But also just that it's not that hard to run. You don't need to be, you know, scared of, oh man, running sims. I don't know if I want to do that. Any questions about this or kind of anything else right now? We have one more presentation downstairs, but I want to give you guys a chance to ask as many questions as you want.
I appreciate this approach. I really like it. I think this is definitely something that could be used, you know. A lot of people hear Sims and like the first thing when I'm like, oh my gosh, simulation.
PTSD from nursing
Yeah,
school.
I'm like, oh
Every
no.
week I hear it.
Yeah.
Oh my God, what a sim.
Relax. Like, it's not that bad.
That's funny.
Yeah, there's downstairs.
We head out. Where are we headed?
Whichever.
Yeah, my stuff's over. Yeah, it's pretty.